Hi, it's Dr. Centeno, and thanks so much for being here today. This is You've Got the Power, and we generally talk about lots of super interesting things here. Also take questions, because at the end of the day, an educated patient is a patient that gets better quicker. So that's really the goal here, is to educate people about various healthcare choices in and around orthobiologics. So today we're going to focus on an interesting topic. I get a lot of questions on this channel about this clinic or that clinic in Central America and South America. And the two most common ones are a clinic in Panama and a clinic in Colombia. So I put together a little presentation today on that topic, just sort of going into what my thoughts are about all of that. And hopefully I'll be able to answer some questions today about that concept of going overseas for stem cell therapy, especially going south of the border, Mexico, Panama, South America, etc. So and as usual, I'll start with a presentation where I'll probably take about 10 minutes to give you my thoughts. And then from there, we'll open this up to Q&A. And you can ask about this topic, or you can really ask about anything else. It doesn't have to be this specific topic. So let me go ahead and start by sharing my screen here. Looks like that worked. And I will then start with a presentation here. I'm just going to double check that everything is showing up out there, just to make sure. Okay, so let me start that presentation, and just going to double check to make sure everything's showing up on just from someone who I have watching. Okay, so Banana Republic Stem Cell Clinics. Let's see here. Great. So the reason why again, I'm doing this topic today is I get a lot of questions on this channel about this clinic or that clinic in Central or South America. And so it's kind of time to start addressing this. I've blogged on this before as well. So there are blogs out there if you go to the regenexx.com blog, but I don't think I've ever done a video on it. So again, a lot of interest in usually the Panama clinic and the clinic in Colombia, and about the concept of going overseas, or at least south of the border, if you will, for stem cells. And again, I've blogged on this, but I don't think I've done a video. So it's time to kind of do a video with Q&A. So there are three issues as I see them, and there's more than this too, but I kind of focus here on these three different issues. One is what I call the IV shotgun versus image-guided local or hyperlocal delivery. Another being sort of blind or low accuracy image-guided injections versus interventional orthobiologics, and what's the difference there? And finally, do you need culture expanded stem cells for what it is you have? So the first idea is this focus on stem cell therapy, intravenous or IV. Now, this is a super easy thing to do, right? You don't have to really hire a physician who's highly compensated. You can just hire a very inexpensive medical assistant to come in, hook the person up to an IV, put a needle in the vein, and then you run the stem cells in that way. The biggest problem is that there's a pulmonary first pass effect. So that means that 97% of these cells will end up in the lungs and nowhere near where you want them to go. And for the other 3% that don't end up in the lungs, all of the areas that we generally treat, or at least most of them, have pretty poor blood supply. So they're really not going, the cells, if they're trying to get a ride through the circulatory system, are not going to make it to where you want them to be in any substantial number. And then finally, we get to the idea that in order to get things to get better or to heal, you've got to place those cells directly in those specific areas. The problem is that's an expensive and very education heavy lift, if you will. And we'll go over that here in a second. So there are some challenges with local or hyperlocal delivery using imaging guidance with things like fluoroscopy and ultrasound. So this is a fluoroscope unit. You know, the first thing is a good one of these now costs about $120K. So you'd have to invest in that. You'd have to invest in a lead-lined room or a specialized room in order to do this. You usually need a rad tech to run a CRM fluoroscope as well. A high-end ultrasound machine will run you $70K. So by the time you outfit a room that does all of this, you're probably in for about $350,000 in order to just start doing this hyperlocal delivery. Now, obviously, that's a lot cheaper than starting an IV, right? You can start an IV for the cost of the disposable stuff. It'll cost you pennies on the dollar to do that. And so there's a big reason why you don't see a lot of this local imaging guided delivery is it's expensive. In addition to that, finding the doctors who know how to do it is very difficult here in the US. So for instance, at our clinic in Colorado, if we had 100 people apply for the position, there are physicians who we thought were qualified, probably only one or two have this kind of training. And then there are very few specialists in this area, and they command big salaries. So obviously, all of a sudden, you take someone like a medical assistant who makes this much, and now if you want to do it this way, you've got to pay a doctor who makes that much. And regrettably, this is not something that your average qualified orthopedic surgeon or spine doctor or spine surgeon is going to be able to pull off. So that's another problem, is you can't just go and hire someone who seems to be qualified for something like this. So what is interventional orthobiologics? And that's really what we're talking about here. And that is that on the one side, we've got simple injections. On the other side, we've got surgery. And when we're talking about Banana Republic stem cell clinics, we're talking about places that generally can only pull off simple injections. And that is something like, for instance, injecting inside a joint. A lot of times they'll do that blind. In fact, one of the clinics we're talking about here today saw a patient down at our Grand Cayman site because that person did need culture expanded stem cells. And they had done a blind knee injection. So that's sort of below the standard of care currently. But simple injections kind of into joints. On the other side, we've got surgery, which is what you're trying to prevent. And in the middle, we've got this interventional orthobiologics. And it's very hard to find physicians who understand how to do this. So what's the difference? Let's use these three joints as an example. So we're talking about in the hip, look at all those different structures that can be injected and would need to be injected to get the best results. So you might need to specifically inject in the labrum under ultrasound. You might need to inject the adductor tendon under ultrasound, or you might need to inject into the bone itself under CRM fluoroscopy, all to get the best results. Now that's completely different than this type of injection where all you're doing is injecting into the joint. Now let's look at the knee. Look at all the different spots that can be injected into a knee and that would need to be injected to get the best results. So again, this is just injecting into the knee joint, whereas this is injecting into these specific structures. So is the ACL loose? Well, great. You've got to do that under CRM fluoroscopy to make that work really well. Do you need to inject inside the bone because the bone itself is having problems? That's something done under X-ray guidance as well. How about injecting the meniscus itself? That's an ultrasound guided procedure? How about injecting something like the lateral hamstrings insertion or the LCL? Those are ultrasound guided procedures. Again, these two things are not equal at all. And down in the banana republics, you're getting this. You're not getting that. And then finally, the shoulder. Look at all these different structures that can be injected in the shoulder. Same thing like we just talked about, meaning some of these are ultrasound guided injections. Some of these are fluoride guided injections. For every 100 physicians who claims they could do something like this, only about 1 or 2 actually has the education, talent, and equipment to be able to inject all those different spots. So another big problem we see with Banana Republic clinics, and I've talked about this before, is that U.S. physicians can't easily be licensed in Central and South America. And that makes sense at some level, right? These countries are big enough to have their own medical schools and produce their own doctors. They don't want U.S. doctors coming down there and getting licensed. That means that obviously everyone's going to want to see a U.S. trained doctor. Now, in the Caribbean, it's the opposite. These are small places that have close ties to the U.S. because that's where they get a lot of their stuff from. And they aren't big enough to produce their own doctors. So they generally encourage U.S. physicians to get licensed down there. Otherwise, they wouldn't have any doctors. So that's why, for instance, we're located in Grand Cayman with a licensed clinic. Anytime we need to go take a patient down there who needs more stem cells, and we grow those stem cells in culture down there. Now, that's not a lot of our patients because only some of them need that kind of stuff, but it allows us to take a U.S. doctor and have that doctor practice down there rather than dealing with the local guys who are licensed down there and who live down there. And at the end of the day, think about this for a second. We're talking about complex image-guided procedures, whether it's that or a gallbladder surgery. Who's going to fly to Panama for a gallbladder surgery? Nobody. Certainly nobody in the U.S., right? I think we'd all know just at gut level that the quality of healthcare someplace here in the U.S., whether it happens to be around the corner for us or whether it might be the next state over, but it's going to be closer to get to an expert physician here in the U.S. than it would be than flying from the U.S. to Panama or Colombia. And then finally, do you need culture expanded cells? Listen, I invented most of the existing procedures using stem cells and image guidance that are in common use today for orthopedic and spine problems. I started doing this work in 2005, long before anybody else on earth was doing image-guided procedures. And I've written and published multiple book chapters, books, and dozens of peer-reviewed research publications in this area. And I can tell you that the vast majority of patients I see can be treated very effectively with platelet-rich plasma. Some of those patients would need bone marrow concentrate, which is a same-day procedure that contains their own stem cells. And then every once in a while, we'll see a patient who does need more cells, and we just take that patient down to the Grand Cayman site where we can grow those cells to bigger numbers in culture and then save those for future use. So not quite sure what the rationale is to fly to Banana Republic clinics to get treatment, given that information and given I've got the world's highest level of experience in this area. Meaning when I started this in 2005, had you asked the average doctor what a stem cell was, they would have given you a blank stare. So in conclusion, IV stem cell injections are not a reasonable way to treat orthopedic or spine problems. Just makes no sense based on what we know and based on the research that's published. And getting these qualified interventional orthobiologic experts is hard enough here in the United States, but almost impossible in a Banana Republic type clinic. So not much rationale for why you'd want to go elsewhere when you can get this care here in the United States, or if you do have to go outside the country because you desperately need culture expanded cells because of the problem that you have, then there are places where U.S. physicians are licensed and you don't have to deal with the Banana Republic doctor. Okay, guys, so I think that should suffice there. I'm going to stop the share and we'll get out of that. And then I will go to questions. Phil, in the same way that you've typically seen a 25% reduction in C1C2 overhang after a PICL procedure, would you expect to see any measurable change in overhang after a posterior PRP at Algocells London? You know, Phil, I haven't tracked that, so that's a hard one for me to say. I can tell you that in patients that we've treated where we've done posterior injections, we really haven't seen big changes in overhang when we've looked. Now, it's a little different there in that we haven't routinely looked as well. But long story short is, as I usually tell patients, if you've got significant upper cervical instability or CCI and you're getting posterior injections, in my experience, that works well about 1 in 5 times. 4 and 5 times we're going on to PICL. So that's usually what's happening there. HRH, can the patient do anything to improve results during phase 3 maturation, reorganization to strong ligaments? I think the biggest thing there is just trying to keep your inflammatory, your systemic inflammation as low as possible. That means eating well, doing some sort of aerobic exercise if possible. It's not always possible in CCI patients. And or taking anti-inflammatory supplements during that time. And then obviously be reasonable with the loading, meaning it's the loading that causes that kind of stuff to get stronger during that time frame. Hi, Dr. Centeno, the rule of Spence, looking for transverse laxity AP overhang as accurate as an ADI value. Similar things are being measured, but realize, Deanna, that all of those measurements, all the neurosurgical measurements, have not been based on any live patient population that has what you have. And that's the difficulty with the neurosurgical measurements, meaning that they're all based on either cadaver studies or patients who have had severe trauma, who need immediate surgery. Whereas the DMX, the reason why we like it is based in the type of patient population we're talking about here, where they took people that didn't have any issues and people that did, and then tried to put them in the appropriate box in a blinded fashion. So that's the difference between these types of measurements. So something like an overhang or ADI that's been measured on DMX is more accurate in identifying problems in this kind of patient population, because there's research in this kind of patient population where they tried to classify people based on that research. That doesn't exist for things like Grab Oaks, as an example. That doesn't exist for a Powers ratio. All of those things are not based on patients who have these sorts of issues. Phil, I had 2 sessions of posterior PRP at C0 through 7, Algocells, and improving. Great. Added CBP to my treatment, and they also found to have hyperkyphosis in my upper thoracic, which is impacting cervical biomechanics. Would posterior PRP in that region also help? Sure, it sounds reasonable to me. I don't know your clinical exam, obviously, but it certainly sounds like a reasonable thing to consider. But I would need to know, obviously, a little bit more after a hands-on exam with you. But certainly adding CBP to try to reduce the load off of the upper cervical spine sounds very reasonable. It's been advanced by Harry Winston. Your own maybe, but is it legal to put someone else's stem cells into a patient IV? Would you think there'd be all sorts of rejection issues? Here in the US, it's not legal to do, no. That's highly illegal. The FDA has been going after clinics that have been doing this. And yeah, there are likely rejection issues. We've seen that in some of the dead umbilical cord products that have been put in IV. In fact, legal expert on a case right now where the guy likely got graft versus host disease, and that's how he got it. And he actually ended up in the hospital in renal failure. So I wouldn't trust that with anything happening in the US at this juncture, because my concern would be something like graft versus host disease. Deanna, what type of trauma force causes transverse damage? Well, alar give up for transverse ligament does in a trauma. So usually flexion force would cause loading on the transverse ligament, and it's kind of not a fair comparison because they're better at preventing movement in different ways. So I'm not sure you could actually compare those two because they do different things. My cervical muscles are always taut and spasming due to guarding of the CCJ. Can the muscles release their tension and return to a more normal state once the CCJ ligaments get tightened down? That's the idea, Liam. So the concept there is to try and reduce the instability by tightening those ligaments, and hence the muscles then won't need to try to stabilize, because they get into spasm primarily because they're trying to do things they weren't designed to do. So they're trying to provide stabilization, whereas the ligaments should be doing that. I see a lot of pain management doctors jumping on the PRP Prolo with little weak ultrasound units, very superficial injections, banking on migratory factor. Yeah, it doesn't happen. I mean, you've got to get into the right spot. And that's one of the big problems I think that's important, whether it's a discussion about Banana Republic clinics or even US clinics who are using ultrasound units only. So if we're talking about, let's say, spine procedures, you have to get directly into that structure. So if you want to inject neck facet joints, for example, then generally that's done under fluoroscopy. It can be done under ultrasound, it just can't be done well on a reliable basis using ultrasound. So fluoroscopy is the gold standard for that with contrast. Same thing if we're talking about the upper cervical joints. I think, as I've said here many times before, you would need not only fluoroscopy, but fluoroscopy with digital subtraction angiography to make sure that you're not inadvertently injecting into the vertebral artery. Trying to do that injection under ultrasound, in my opinion, is not good and below the standard of care, because the kind of accuracy you can have with ultrasound at that depth, and make sure you're not in an artery, is far, far less than you can with fluoroscopy using digital subtraction. Fern just got my PRP injections last Friday. Great, Fern. Dan, I have this fear of walking now because my bobblehead is so debilitating. I have C1-C2 overhang. What cause more damage to my alar ligament? Probably not, Diana. So I don't think it's healthy to develop fear of things like walking. I think that you want to do as much as you're able to do without going over that line. So for instance, you wouldn't want to take up marathon running, but I think walking is something you should try to do as much as you possibly can. Question: last week with the enlarged ADI space after treatment, her ADI was V-shaped, and I see a lot, you have V-shaped ADI where it's tight in the bottom. Would you expect the injury to be, or is V-shape a normal variant? Yeah, Robert. So generally, V-shape would be the least laxity in the transverse ligament. And then as the transverse ligament gets weaker and weaker, you tend to get more open atlantodental interspace, or ADI. So at the end of the day, a V-shaped ADI is certainly an improvement over one that's opening like this, and that's the transverse ligament. Do you have this PowerPoint slide on your website? No, but this is being recorded in all three channels. So the two Facebook pages, Centeno-Schultz and Regenexx, as well as YouTube. So it'll all be up there. Deanna, do you treat osteoarthritis with inflammation in fingers with PRP? My mom has the condition causing her fingers become crooked. She does not have rheumatoid arthritis. We do treat osteoarthritis with inflammation in the finger joints. That's frequently done with PRP, depending on the severity. But yes, that's something that generally works pretty well. Now, the big thing you've got to sometimes look at is whether or not there's instability. And that makes it a little bit more complex because then you've got to get the collateral ligaments on the side as well. Deanna, what specific ligaments can the upper facet injections help in CCI? Your last videos explained injections can help with pain and bobblehead too. It's not so much the ligaments when it comes to upper facet injections, other than perhaps tightening down the capsule, which can act as a kind of ligament. But the main stabilizer ligaments, things like alar, transverse, accessory, etc., would not be changed by injecting those joints. Those joints are generally injected because when there's chronic instability, they get beat up and arthritic and then cause pain themselves. So they usually need to be treated separately if that's been going on for a while. And in a lot of CCI patients, it has. Pia, I got anatomy trains today. Thank you for recommendations. Do you happen to have any other book recommendations? Pia, let me think about that one as far as that might be helpful for a patient. Obviously, the anatomy trains one by Tom Mayer is really good. And let me see if I can find that and put that up, because I don't get any money from Tom Mayer here or Anatomy Trains, but I love this book. And it's a really good one if you want to look at how the body is connected. Here we are. So I'm just going to put this up and share this so everyone can see it here. If you're interested in buying that book, this is the link to Amazon. So great book. It goes into how the body is connected from head to toe, and it's super fascinating to see. So it looks like you can rent it for $20 here on Amazon. Like I said, I've never rented a book before on Amazon, so I'm not quite sure what that means. Maybe you have it for a certain amount of time or something like that. Robert, I missed how you came up with the Banana Republic term, LOL. Oh, Robert, just talking about Central American and South American clinics, again, to try to differentiate the pretty big difference between medical education in the US in the first world and medical education in the third world. So big differences and gaps, obviously, there between education and also what's available, right? In the first world, you've got doctors that are using more advanced technologies, so they get to understand how those work. In the third world, less opportunity to use those technologies at the cutting edge. Robert, my current thing is if I press the back of my head down and forward, I feel better and want to stay there. Does it indicate posterior anterior issue? Yeah, so that's probably more of a problem with the anterior ligaments here, either anterior longitudinal ligament or some of the extensions that go higher up there. So let's see here. Let's see if I can find some of that for you. Well, I seem to be striking out. That's the problem with having almost 4,000 blogs, is that it is not easy to find something when you're looking for it. Oh, well, anyway, all the ligaments up front here, and usually if we're talking about CCI, those are the ligaments between the atlas and the skull up front. So so if you're back like this, that's going to put those ligaments under stretch and cause more problems. If you're down like this, obviously that's going to feel better. So usually an anterior ligament problem is what that is indicating. Robert, can ultrasound detect torn tendons within the occiput and the capitis muscles? Torn tendons are not easy to identify as long as we're talking about things that are torn and pulled back like a rubber band. That's much less common up there. Usually what you see is tendinopathy or small partial tears. And you can look at some of that on ultrasound. Sometimes you can see those on MRI. And then sometimes it's just based on clinical exam because these muscles are relatively small compared to big ones like you might look at in the hamstrings, for example. Anya, is it worth doing upper cervical MRI, craniovertebral region? I think it shows more upper cervical ligaments than normal MRI. Yeah, Anya. So the answer is yes and no. So I think the research you're talking about is done by Crockiness. And there's probably a blog on that from way, way, way back. So you can look at those upper cervical ligaments. That's probably not it. But you can look at those upper cervical ligaments on a 3 Tesla or a 1.5 Tesla MRI using a head coil, not a neck coil. And that's a closed bore unit. And if you use that kind of thing, you can see those ligaments. The difficulty comes in trying to know what's normal and abnormal. Now, some research was done by a guy named Crockiness, who is a neuroradiologist, or was, he may be retired now, in Norway. And this is U.S. Library of Medicine. And so Crockiness published some of these papers here back in the 2010 timeframe. And then actually I met Crockiness. He had come out to do lecture and he stayed with me and got to know him a little bit. And I know that he was under tremendous pressure by physicians in Norway who didn't really like the fact that he all of a sudden had opened this idea, this Pandora's box, if you will, of that you could use certain types of MRI to see these ligaments and that those ligaments might have problems. So he then kind of backed off some of that, I suspect, for his own purposes. That's my own opinion. But long story short is you can look at them. The problem is you still then don't know whether or not the ligament function is abnormal, meaning if it doesn't look good in MRI, does that mean it needs to be treated? And the answer is nobody knows. That's why we tend to use digital motion X-ray, because it shows if that ligament has a specific problem that's functional, meaning it's allowing too much motion to occur. So that's really the difference there. So the answer is you can look at them using specialized MRI. The question is, how valuable is that in planning treatment? Now, I have gotten to the point where, there are certain experts out there. Scott Rosa is one in upstate New York. And I think Scott has enough experience in this area to be able to assist me with trying to find specific structures to treat. And I have had great success in trusting Scott's reads on some of the MRIs that he does. Robert, PRP quality. I'm sure you've answered in the past. How different are PRP preparations? Oh, they're hugely different. So for example, we've got low dose PRP. So for instance, one of the largest companies out there, Arthrex in orthopedics, sells a unit that makes what's called ACP, autologous conditioned plasma. And it's basically subpar PRP. PRP minimum is 2x, as defined by Marks et al., and ACP is way down there. Now, a lot of orthopedic clinics, because they're used to dealing with Arthrex, have that ACP unit, but it doesn't even meet the minimum definition for PRP, which is 2x. Then you get into the moderate level, and then you get into higher level, and then you get into lab stuff, which is what we do, which is even higher than that. And we're talking now about concentration. Now, if you're 20 years old, the concentration probably doesn't make a lot of difference. So if you're getting treated with a 2 or 3x PRP, meaning 2 or 3 times concentrated, you're probably good if you're 25. But once you get to be an old guy like me, or anyone with any kind of age, 35 or 40 and up, we're now in a situation where concentration probably makes a dramatic difference based on the existing peer-reviewed published literature, meaning that you're likely to do much, much better with a much, much higher concentration PRP as you get older. So that's sort of the big difference there. Linda, I'm seeing you on September 7th for a consult. Have had 3 PICLs with you. Last one, September 2021. Haven't had any imaging other than for Cairo since 2017. We've been beneficial to me to get upright MRI. Linda, if you really want to get additional imaging and you've had several PICLs, a repeat DMX, only looking at the flexion extension and the open mouth lateral bending, that might be very helpful to see where things are, their stability. In general, that's going to be more valuable to me than getting an upper cervical or a cervical MRI. Now, obviously, if things have somehow changed that might necessitate an MRI, let's say in the last couple of years, you started to get stuff down an arm and we're suspecting a disc bulge at C5-6, then that's something that you may want to take a look at. Judy, any foods or vitamins to avoid before and after PRP? And hip, tried A2M a year ago. Don't really know if it worked. Wanted to have embryonic stem cells, but can't afford a local doctor, Harrison. So Judy, there's no such thing as embryonic stem cells here in the United States or any kind of fetal stem cells here in the United States. So that's a scam if someone told you that they're injecting young stem cells from birth tissues, umbilical, amniotic, etc. Meaning we've done that research. Others have done that research. In fact, I'm on PubMed. I'll pull up our research here. Let's see here. Here we go. So we published that in the American Journal of Sports Medicine. That's actually the highest quality orthopedic journal that's out there of 71 orthopedic journals. And we looked at whether or not commercial umbilical cord products that were being advertised by clinics actually had any living stem cells. And none of the 5 products that we randomly tested had any viable or living stem cells. So that's a scam. So I'd run if someone told you there were stem cells in these things, because they're not paying attention to the research. And then as far as what you might need, whether it's PRP, A2M, or something else, obviously I'd need to know more clinically. Robert, had 3 0-1 injection rounds. I did feel relief after first 2, but quickly got messed up again. After my third, nothing took this time. Yeah, Robert, I need to know more about your situation. It almost sounds like you might need something like PICL, but I'd need to know more about what's going on with you clinically. Linda, also with cervical and upper thoracic scoliosis, would I be looking at PRP or a stem cell best to treat that? Generally, Linda, we will use PRP or platelet-based products to treat cervical and thoracic scoliosis. That's called the scolioplasty procedure. Let's see if I can pull something up about that for you and give you something to read. So scolioplasty. Yeah, so this is a good example. You're not going to see that, but this is a good example of what I'm talking about here. This is a good blog to read. Just go to the regenexx.com, 2X's website, search here under scoliosis. And this talks about the patient. Here's the actual patient MRI. So pretty severe and significant scoliosis, which was degenerative here in this patient. And then it talks about how that gets treated, meaning on the side of the convexity, we're injecting ligaments, tendons, and muscles that are getting stretched. On the side of the concavity, we're injecting facet joints and nerves that get impressed. Deanna, is it harmful to muscle tissues like occipital to be injected with posterior prolotherapy solution? Yeah, Deanna, you wouldn't want to inject into muscles themselves. Realize that a muscle has a couple parts, right? On either end are the tendons, and that's something that would respond well to prolotherapy. And then in the middle is the muscle belly, not something that you'd want to inject with prolotherapy solution. So for instance, you could use a platelet spiked prolotherapy solution on either tendon, but when it comes to the muscle in itself, based on the existing literature, platelet poor plasma is something that you might consider putting in the muscle belly. But you wouldn't want to inject, you're right, you wouldn't want to inject a muscle belly with prolotherapy solution. Deanna, can the PICL procedure anesthesia set up and mouth device shift atlas out of place? Set into extreme extension. Many patients seem to see NUCA or AO after. Not in extension. There's a little bit of flexion that's used with most PICL procedures. But certainly just from getting knocked out and then from being woken up and having to assist in turning yourself over, people can get knocked out of place. So that's usually the reason why we would recommend, if they're getting good success with NUCA or AO, that they consider getting NUCA or AO after the procedure. And that seems to work pretty well for our patients. Anya, thank you very much. Going to ask if there's any research on whether there are differences in pain and stability improvement with injecting facets with contrast versus injecting facet capsules. I don't think anyone's ever looked at that particular research, primarily because the standard of care currently is to inject inside the facet with contrast and not to inject what's called the capsule, meaning that when someone says they're injecting facet capsule, they're not injecting the facets at all. They're just kind of putting the needle along the back of the spine where the facet joints live. So we don't have any idea if they're injecting the capsules or not. They're just kind of going into that general vicinity. That's very different than injecting a facet using fluoroscopy and contrast. But no one's ever compared that, primarily because the standard of care is currently to inject inside the facet using fluoroscopy, not just sort of in the general vicinity. Robert, which ligaments affect a low CXA? Same ones we were talking about before. Oh, no, actually, Robert, the other opposite direction. So let's go here and let's look at CXA measurement. And let's think about all of that for a second. Okay, so what's a good picture to show you guys? Maybe this one. Okay, so we have here different CXAs, right? 150, 140, 120. And the front is actually this side towards the right of the screen. So if you've got a very high CXA, your head is going to be back this way. So that's going to be those anterior ligaments. Now, what's a high CXA? 155 and or higher. Now, if we go to a very low CXA towards the bottom, and remember, front is towards the right of the screen. Now we have the skull that's doing this kind of thing. So if it's doing that kind of thing, that's going to put more pressure on the back of the neck. And if we have a high CXA, that's going to be opening up and putting pressure on the front of the neck ligaments here. So those are those same ligaments we were talking about before. So high CXA is going to put pressure on or pull on those upper neck ligaments that live between the atlas and the skull in the front. And if we've got a low CXA, that's going to put pressure on the ligaments that live back here in the back. Now, what is a low CXA? It's a good question. Somewhere, something under 130 to 135 is usually considered a low CXA. HRH, where your patients who have a 4-month follow-up while you're on vacation be bumped. Following month are transferred to Dr. Schultz. Usually we don't mix patients. Schultz is going to be out during that time as well. So it's kind of 6 of one, half dozen the other right now because Schultz is getting married. So he'll be out a chunk of September anyway. So I'll be there the first 2 weeks of September. I think he'll be out the second 2 weeks of September, probably through early October. But we generally don't move patients between doctors just because it's hard to get up to snuff on someone and feel comfortable that you know all the different parts and pieces of what's going on with them. Deanna, have you seen many patients return to their previous baseline after PICL? Used to lift weights and dance competitively, and I'm sure where the future holds with treatment. I think, Deanna, as I've said before, a lot of that depends on how deep the hole is and how long this has been going on. So if the person is a high-functioning individual, so let's see here. Actually, this just happened today. I have a patient who is a competitive equestrian in polo. And we treated her right before polo season began. She had pulled back quite a bit, but she was still pretty high functioning. And she's about 30, 40% better after the first PICL. I haven't recommended that she continue to play polo, but this is her life. So she has, meaning, everything from her social group to the way she earns an income is tied into polo. And so she's just continued to play through. Now she's fairly high functioning. Do I think that she'll get back to 100%? Probably, or close to it. Now, then compare that to someone who can't do anything like that, who has a hard time riding in a car. Is that person going to get back to something like competitive dance or polo or running marathons? Probably not. I think the goal for that person would likely be, depending on how long they've had the problem, getting them functional so they can function in their life, work, etc., but not to go back to something like competitive dance. So a lot of that depends on how deep the hole is and how long you've been there and how much the delta is between where you are and where you want to be. Barb, I'm 6'9", had stem cells on my knee 3 years ago. How often do people repeat that procedure? How long should I expect results? Barb, I need to know a little bit more about what you had done. There's lots of different treatments out there, obviously. So are we talking about bone marrow concentrate in the knee? If so, are we talking about just into the joint or the joint plus the bone? Those are the kind of things I would need to know to answer that question. Just to give you for example, for knee osteoarthritis patients who have intra-articular, meaning just inside the joint, bone marrow concentrate, we're talking 2 to 7 years on average. If the bone is added based on the existing recent research, that could be extended out to the 15-year mark in general. Judy, what foods and vitamins should you avoid before and after PRP injections for hip osteoporosis? Judy, we generally don't do PRP injections for hip osteoporosis, so I need to know more about the diagnosis there. Maybe you're thinking of osteoarthritis. When it comes to food and vitamins, we'd want you on a low inflammatory diet and a low glycemic diet. And Dr. Pitts has got an excellent book on that. So I'm going to pull it up here for you on the regenexx site. Hopefully I can find it. So if you go under regenexx resources and then under ebooks and reports, Dr. Schultz's book is right. Well, let's not do that. Dr. Schultz's book is right here, Nutrition 2.0. That's a really good one to read if you're considering any kind of dietary changes prior to these sorts of procedures. Judy, how do you explain Harrison Ford and his dad's results with umbilical cord embryonic stem tissue cells? Judy, I don't know what's wrong with Harrison Ford's dad, so I have no idea what it is we're talking about here. So I would need to know a lot more about what's going on with Harrison Ford's dad. Anya, can I ask why standard of care is to inject for septic contrast? No research in the terms of differences in outcomes. Yeah, Anya, that has to do with possible complications. Standard of care is defined by the majority of physicians that do this kind of work. And if you're injecting a facet, for example, the current standard is that you've got to use X-ray guide and contrast. So let's say there's a problem, right? Let's say you do that injection under ultrasound and the person gets a high spinal and the doctor doesn't have resuscitation equipment. Just that you know, a high spinal means that there's anesthetic getting injected intradural or inside the cord. My guess is you're going to have a hard time defending yourself in a court of law because this standard of care was violated. Now, who determines the standard of care? Most of the doctors that do this kind of work determine that standard of care. So there doesn't have to be research showing one is better than the other. In 99, well, not maybe that high, 95% of medicine, we don't have research on a lot of the things we do. Francis, since you like to do watchdog kind of stuff, would you have an interest in testing a sample of lab-grown cells from American Cell Technology to see how much they suck? Sure. Francis, a lot of that depends on the research stuff that's going on in the lab at any given time. But if you want to PM me, feel free to, and we'll see if that's something that we can throw into culture and see what's there. That would be interesting. Now, realize that just the chain of custody there is going to be pretty complicated, right? Cells go from negative 150 C, which is where they're usually stored long-term, then to 80 degrees C, meaning negative 80, and then to a negative 20, and then they're controlled rate thawed. Now, simply shipping something like that's a big deal because you'd have to ship it in what's called a Credo cube. It's a big old thing like this for a little tiny bit of cells. To keep that temperature stable, you'd have to make sure that you were shipping it in a pressure and temperature controlled compartment in a plane, which is not trivial, meaning that there aren't that many of those out there because we've looked into it. And it's very, very expensive to ship biologic samples like that, meaning you can't just throw it in your luggage in the bottom of a plane because that's not pressure and temperature controlled. So there'll be a lot of questions about the chain of custody of those cells, other than if someone told you you can just put them in the freezer and that's fine, and you've got that in writing, in which case that's clearly going to end up in dead cells because you can't just throw them in a negative 20 freezer. Rolandis, best wishes. Hey, Rolandis. NMN protocol, Judy, I don't know what you're talking about there, so you need to go ahead and figure out all of this. Barb looks like injected in the kneecap. So Barb, if it was injected into the bone, then I would say we're looking at more long-term results than if it was just injected into the joint. So I'd need to know joint, bone, or both there. Question, do low inflammation foods disrupt PRP like turmeric, CBD, other? No, for example, turmeric goes through a lipooxygenase or LOX pathway rather than cyclooxygenase. So we're okay with turmeric or curcumin. CBD, I'd have to do some more research on. I don't consider CBD anti-inflammatory at this point. So as long as we're going through that LOX pathway, we're generally good. Great. There's the link to Dr. Pitz's stuff. As someone with trauma-induced CCI, should get tested for EDS or MCAS to help guide your treatment plan. I don't really have any signs of EDS, but do have hyperextended knees. Deanna, I don't think you need to get tested for EDS as much as just go to Google and type in Beighton score, Biehton score, and you'll see Beighton testing coming up. So it looks like this, and you can actually score yourself. So if you've got a 5 out of 9 or greater, then we'd consider you to be hypermobile. Just realize that it's not trivial to get genetic testing for EDS. For whatever reason, at least here in the US, it's pretty hard to get. So this is a good proxy to see if you're hypermobile. If you're not hypermobile, great, shouldn't really impact things very much. And then whether or not you've got MCAS or not, again, usually doesn't impact our world very much either. Simply because if you think you're highly allergic to things, we're probably just going to give you some IV Benadryl during the procedure. Realize that sort of 1 in 4 to 1 in 5 of our CCI patients now either have MCAS or mast cell disorder, and we don't have any issues with those patients as long as we just use IV Benadryl. Okay, guys, so we are at 1:56. We've been at this for almost an hour. I'm going to start wrapping this up and happy to answer any other last minute questions as they come in. So what we were talking about today was just the concept of Banana Republic clinics and going down south to get musculoskeletal issues treated. Let's see, one more question here. Anya, can injections of facets replace foraminotomy? I have severe facet pain. I'm wondering if the nerves are compressed from the stenosis. Can injections help? I have burning pain in the arms. You know, Anya, that's a more difficult question than it seems. So a lot of that would depend on how much foraminal stenosis there is and how much instability there is superimposed upon the foraminal stenosis. So what I mean by that is realize that the foramen is made, so it's a hole where the nerve comes out, right? See if I can get this right here. And you've got the part of the hole that's made up from the top vertebra and the part of the hole that's made up from the bottom vertebra. So if that hole gets a little smaller, that's one thing. But if there's instability on top of that between those vertebra, then the nerve is going to get even more pinched. So with instability, and if you can provide stability through injecting ligaments, that'll make a huge difference in patients with foraminal stenosis. So that's what we're talking about here from a treatment perspective. Now, if it's severe foraminal stenosis and there's other things like what's called myelomalacia, which would be a change in signal in the cord, then we might be in an all bets are off type situation with these sorts of procedures being unlikely to help. Rolandis, some patients are asking me for PL injection 0 to 3 with Dr. Kirkor. Would you please recommend? Yeah, so I think, Rolandis, what's happened with Dr. Kirkor is they've decided not to treat CCI patients in their London clinic. So I believe that's what's happened. Maybe that's changed, but I'm pretty sure maybe some of the UK guys can jump in on that. Okay, guys, so I'm going to go ahead and wrap this up. I want to thank everyone for spending the time today. And in addition, I think I'll be here on Friday doing this again. We'll see what kind of topic we come up with for Friday. I always love when patients recommend topics or things they want to hear about. So if you can put those in the comments, that would be great. And you have a fantastic week out there. And remember, an educated patient is so much more powerful, if you will, than one that's not educated. So thank you so much for your time today.